Yeah, let me jump in first because I'm afraid I have to jump off the call in a few minutes at the top of the hour. So actually, the thing that I think is most inevitable over the next 10 years, since that time frame you asked about, is a change of public attitudes with regard to what's going to happen in the subsequent 10 or 20 years. At the moment, almost everybody in the world still believes that they're probably going to live only a few years longer than their parents did. And indeed, that they're going to stay healthy for only a few years longer than their parents did. And I'm convinced that there will be a tipping point where the results, and indeed the public statements of people like myself and David, are going to change that. And when they do, those changes are going to happen very suddenly. I believe there's going to be a really sharp tipping point when people like Oprah Winfrey get on board with this, that is going to going to herald a very turbulent few years while we figure out what to do with the general belief on most people's parts that they're going to live healthily for a lot longer than their parents did. This is something that I don't think anybody's really ready for, whether it's in governments or in the financial services sector or wherever. And I think that it's very likely to happen within the next 10 years. I would say it's quite likely to happen within the next 5 years.
Yeah, Aubrey, well said. I can feel it already in society. I think this Clubhouse meeting here is evidence of that. We're living through this really historical moment where I don't know if you've followed Aubrey and me for that long, but even just 10 years ago and certainly 20 years ago, we were really on the fringe and people thought we were crazy. And it was actually, frankly, close to career ending to talk about age reversal. I think it was about 7 years ago I first started using that term, and it was outrageous at a talk at Stanford. So now it's not mainstream, but it's about to break through, and it's an exciting time. I just want to add, what else will I see in 10 years? I think it'll be common to be monitored by your doctor. It'll be common to take senolytic cocktails. It'll be common to treat diseases with therapies that reverse aging. Whether it's the eye or the whole body, I don't know, but I'm certain there will be ways to reverse age, not just by a few years. And Greg, your work is amazing and awesome. Thank you for that. But by a decade or two. And we've seen, at least in animals now, that the epigenetic age reset and the restoration of vision, it goes on for a long time. This may be, quote unquote, a permanent reset until you age out again, and then you can keep resetting the body. And we don't know how many times you can reset the body yet. We know it works once, but I would bet that it works 10 or 100 times. And then we're really talking about a change in the way we can view our lifespan.
By the way, we're very interested in that same question with respect to the thymus, David. If we regenerate the thymus, can we then regenerate it again and again? So that's something we look forward to finding out.
Oh, so I guess I'll chime in here. I agree with that. I think that a lot of what you're going to see is attitudes changing, and I think that's fantastic, and that's absolutely necessary. You're going to see the slow drive of data that's going to start to come through scientific papers showing extended lifespans in model organisms and then soon in humans. You're going to hear more people talk about it, but of course an obstacle is always how difficult it is for small companies to get into clinical trials. So right now I'm doing my thesis for my MBA, and it's vastly on a new route of regulation, not through the FDA, going around the FDA, but through the same departments of Human and Health Services in order to get people who are terminally ill access to better drugs. And so the right to try doesn't give access to the drugs that we're talking about today. I call them best choice medicine, and that's drugs that perform better in early basic research than anything we have available on the market. And those drugs exist, and that's what everyone on this call is talking about. But these are still vastly experimental, but without human data, we can't really get to them. So hopefully we'll get the regulators to look at new routes that indemnify themselves from the difficult choices that they have to make in making decisions about new drugs. People will see that. They will see new options open for patients to take part in. They'll see more data coming out. And what can block us is, of course, the enormous amount of money that it costs otherwise to get to even the regulatory service. Millions and millions of dollars worth of animal data that, again, is not a very good predictor. And then the $2.6 billion estimate from past Tufts University to actually get a drug approved. Let's remove those roadblocks.
Anybody else want to chime in about intrinsically knowing what the next decade looks like?
I can tell you what our provisional roadmap is, if you'd like.
Yeah, please. They'll definitely be based on your system, on your things that you kind of believe.
Right. Our vision is to make 90 the new 50 by 2030. We deliberately chose a falsifiable goal, 2030. That's 8.5 years from now. So we have to figure out where the holes are that would prevent that from happening. And so, in no particular order, we need to be able to deliver biological payloads to select body compartments far better than is available today. So delivery as a whole, we need reliable, high-quality bulk cell supplies. Right now, there's not nearly enough high-quality cells available to purchase. One of the biggest rate limiters for the competitors in the vascular tissue challenge competition was they just couldn't get the cells in order to do their organoid constructs. So we need high, reliable bulk cell supplies. Distribution. Who's going to deliver these interventions? It's going to be licensed practitioners. Do any of them know anything about what we're doing in significant numbers? My experience is that physicians pretty much stop reading papers the day they get out of the university because they have no time. They're spending all their time dealing with insurance companies and such. And of course, I'm speaking hyperbolically. I know there are exceptions, and they're wonderful. So also, trusted validation. Do you know that the pill that you're taking actually has any of the crud you're actually trying to get inside of you? I have no idea if the stuff I'm taking is actually the stuff I think I'm taking. That's missing. Let's see. The regulators need to accept patient trials in a dish because models that are based on animal models are awful. They're not just not very good, they're awful. And they're awful in ways that people don't even think of anymore. If you were to say, is it okay to just take these animals and torture them and ruin them and break them apart and stick things in them? No, it's not okay. It's just what we have to do today. We have to get away from that. It's a moral imperative. Aside from patient trials, and just much better. Vastly better in terms of speed and accuracy of coming up with interventions. Engineered functional organs, so we need to go to a next level for the vascular tissue challenge to scale it up to actual clinically relevant constructs like liver patches and so forth. Optimized nutrition biofeedback. Okay, you're eating this leaf. Is it really good? Sure, it says organic, but is there anything in it that I need? And by the way, what do I need? And that's based on our Deep Space Food Challenge with NASA. You should perhaps look that up. Deep Space Food Challenge is a wonderful challenge being put on by NASA and Methuselah. Individuals need to own their own biodata so that they can get prescriptions and diagnosis. This might go on to the blockchain. And then, let's see, one more thing. There's always one more thing. I think I've taken up too much time. Sorry.
I might add very briefly, because I'm sure we want to get to questions, that, and hopefully this is a safe prediction, that the enthusiasm for longevity research and the funding that goes along with that continues to increase in the next 10 years. That's all I wanted to add.
2 quick points. I certainly think that in terms of longevity, as John was saying, yes, I think it's going to increase. People are not going to get younger. We still have an aging population, so there will continue to be interest in developing interventions. So I certainly see the development of longevity pharmacology and longevity drugs as becoming a reality in the next 10 years. I'm a little less optimistic about rejuvenation technologies or reversing aging. First, because we don't really know how to do it even in animal models. We can manipulate aging, we can delay aging in animal models, including in mice, but we don't know how to reverse aging. So I think there's still a lot we have to figure out in that context. I think there's some promising approaches. David Sinclair were talking about the Yamanaka factors, or 3 of the Yamanaka factors that they've used, but it's still not very clear how you then turn that into a human therapy, for instance. So I would say the next 10 years, yes, I see a continued growth in longevity industry, longevity biotech, research on aging, development of longevity drugs, but not necessarily, unless there's a big massive discovery, not necessarily on reversing aging or rejuvenation technologies.
Thank you, Pedro. I want to give a chance to Alexandra and Greg to perhaps also answer this before we go into the Q&A. We're very happy to have so many people interested in asking questions and wanting to chime in the conversation. We just wanted to move this along. As you saw, a couple of our speakers had to leave, so I want to make sure that we get to answer as many questions as possible, as other of our speakers probably have to leave as well. But Alexandra, Greg, want to chime in?
I'll let Alexandra go first.
Okay, if you want to. I would hope that people would take more interest in their own health and would become more empowered, and all these kind of like positive signs that are coming from the trials that are currently running would kind of inspire them to really become invested in their own health and try out more and pay more attention to their health. So I would hope that this is a trend that carries on and becomes bigger.
And I just think that the example that we're trying to set, which is to show that aging intervention can be done now, begins to catch on as a concept. And as the evidence accumulates, I think it'll become more and more obvious something significant is actually happening. Sergey Young has recently bought into the idea of using repurposed drugs to advance the cause of aging intervention. I think it's a really good idea because the barriers to getting these things through FDA approval process are quite light. For example, with our therapy, we were able to show statistically significant improvements in kidney function in 9 guys in a 1-year period of time. So if that could be made into a yardstick for FDA approval, we should have a ridiculously easy time compared to people who are attempting to develop entirely new drug entities. And by the way, there are ways that we can improve human growth hormone to make that into a separately approvable drug that we can essentially own ourselves as well, so that even though it's a repurposed drug, it's effectively a new drug. So this kind of paradigm, if this leads to early signs that you can actually do something meaningful on a clinical basis about aging, not in 10 years or 20 years, but maybe in 1 or 2 or 3 years, then I do think the attitudes will begin to change in an optimistic direction. I'm already seeing lots of signs of this. I'm seeing increasing enthusiasm over the possibility. So I do think that there is a sea change coming, and it's going to be boosted by many different advances that are all coming into aging from different directions. But I think that we're beginning to see signs of this happening already.